Hi, welcome to the Spine MDT. Today's video is about anterior cervical discectomy and fusion. Perhaps you've been offered this operation by either myself or another surgeon, so the idea of this video is just to go through the procedure so you understand the benefits, the risks, what the procedure involves. I've previously done a video on YouTube on cervical radiculopathy and breakalgia, one of the indications for the operation, so please feel free to check out the video, click on the link, and also subscribe to the channel. That always helps. I've also recently written a blog article on the operation anterior cervical discectomy and fusion, so let's dive straight in. One of the other indications, as well as radiculopathy for the procedure, is myelopathy, and that's resulting in compression of the spinal cord. So we can see here, this is a scan of a patient's cervical spine. You can see the silhouette here of the neck, the chin, front of the mouth and nose, and the back of the neck here. And this is the neck part of the spine, which contains and protects the spinal cord, this grey structure here. Between each bone here that makes up the spine, you've got these little cushions called discs, and you can see at this level here, this disc is protruding outwards and pinching the spinal cord, and that causes myelopathy, which is dysfunction of the spinal cord. Often presents as weakness of either the arms or legs, loss of balance, loss of function of the arms and legs. So the operation is carried out under a general anaesthetic. Once you're put to sleep, you have a dose of antibiotics intravenously, which help prevent infection. Regardless of which side your symptoms are predominantly on, I always go in through just to the right of the midline. It's generally a safer approach. So the incision is normally buried in one of two skin creases we all have in the neck. That gives you a better cosmetic result. And my incision is usually across, usually from the midline to about here. Between your windpipe and this muscle here, there's a blood vessel there, the carotid artery, and along here there's the approach I take that gets you to the front of the spine. So back to my blog article, once you get to the front of the spine and the retractors are in, this is the view you usually have. So these are looking at the front of the spine here in the neck. This is the retractor system we use to protect all the surrounding tissues. These are the bones of the spine, and in between are the discs. So with a knife we make a cut into the disc and then start to thoroughly remove all of that disc material. This is a side view here, front of the spine, spinal cord, and you can see here the disc that's pinching on the spinal cord. So I go in and remove it and then roughen up what we call the end plate, each bone on either side, so we expose some of the inner bone to the outside. Once that's done, we place in a breeze block called a cage, and this is what they look like. This is made of a special type of thermoplastic called PEEK. Other ones are made of titanium, and you can see a little hole here in the middle where we use some of your own bone graft, normally from the knobbly bits of bone that you get poking out at the front of each vertebral body, plus a combination of some artificial bone graft. And then the cage is placed in to replace that disc, and it allows, with time, the bone above and below to fuse up. Depending on your scan and whether there's possibly some instability, I sometimes like to use this type of cage here, which has a couple of screws, but that's very rare. So going back, this is what it looks like before, with a disc poking out, pinching the spinal cord, front, back. Once the disc is out, you can see the spinal cord and the surrounding nerves are completely free. And once that's done, we then close the wound with some stitches, and I usually leave a drain coming out the front of the neck to prevent any blood collecting at the front of the spine around your windpipe or even around the spinal cord. So if you go back to the reason to do the procedure, the purpose of the procedure is to alleviate some of the symptoms, specifically pain that you might have radiating down the arms. With things like dysfunction or loss of function, so weakness in the arms and legs, or numbness, specifically weakness, with time that improves. The main purpose is to preserve the current function, but in my experience, with time, weakness improves. Numbness is a little bit less predictive. In some cases it improves, but in some patients it often remains. Now, every procedure under the sun has risks, and I've taken a lot of these from the information given on the British Association of Spine Surgeons, which I also give out to patients. This is for the purpose of consent, you understanding the procedure before giving your consent to go ahead. The most serious risk with this operation being operating around the spinal cord is damage to the spinal cord from either blood compressing it or damage to any blood vessels, or direct damage that can cause paralysis. Every measure is taken to try and reverse that. So if there's a big blood clot around it, we would go back in, wash it out and try to alleviate that. But extremely rarely, in very extreme rare circumstances, in the literature at least, that can be permanent. Other risks include infection. Most of the time that's superficial, that can be treated with antibiotics. Very rarely that infection can be deep and might need a second operation to go through it. In your neck are big blood vessels in this area, and also the tissues can ooze. So blood vessels that bleed, or any bleeding in that area, can compress the windpipe. In an emergency, we have to reopen to restore breathing. Again, look, these are extremely rare things to happen. The lining of the spine of the spinal cord contains fluid in it. You can sometimes get a leakage from that's usually repaired there and then. That very rarely needs a second operation. Some patients, if you fuse one segment of the spine and therefore reduce the mobility of that segment of the spine, then the adjacent levels have to do a bit more work to make up for that loss, and there's a phenomenon of adjacent level disease, which means you can have the same problem occurring later on at other levels. But with the physiotherapy exercises we teach you, and if you maintain a good alignment and posture and strength of the muscles that support your neck, you can help prevent that. And there's some other rarer risks outlined in the blog and on the British Association of Spine Surgeons booklet, which I'll also leave a link below. I also briefly talk about anterior cervical disc replacement. That's where, instead of the cage that we talk about here, there's an artificial disc which allows a degree of movement. I tend not to carry out this procedure myself because a recent study published in a centre in Europe that has a high volume of disc replacement compared it with this operation, the anterior cervical discectomy, and it showed no difference in the rate of adjacent level disease, but a slightly higher complication rate. And for that reason, I tend not to carry out that procedure. Another procedure that's an alternative when you don't have spinal cord compression is called a posterior cervical foraminotomy, where you go in from the back of the neck. I discussed that briefly in the previously mentioned YouTube video on what is cervical radiculopathy, but remember that's specifically if you don't have spinal cord compression. In terms of recovery, most patients tend to go home the next day. You can experience some pain and discomfort and stiffness in the neck in the first few weeks, but if you do the exercises that my physiotherapist normally give you that work on the extensor muscles and deep flexor muscles on the neck, that slowly subsides week after week within a few weeks. With most spine operations, I tend to advise just a few weeks off work to allow you to recover, but in that time I certainly expect you to be mobile, doing the exercises the physiotherapists give you and actually getting out and about. I usually use absorbable stitches, so they usually dissolve on their own, but I try and keep the wound dry within the first week or so. I hope you found the video helpful. Please subscribe to the channel for more videos I do on back pain and spine care. The goal at the Spine MDT is to find the least invasive solution that gives you the longest lasting results. Please visit our website, the link is below. Call us or email us and we'll be very happy to help you. Thank you.